Good morning. My name is Mel Kapp, and I'm Chair of the Board of Directors of the Health Research Foundation of Innovative Medicines Canada. I'm proud to welcome you to the Health Research Foundation Annual Conference. Over 50 years ago, Innovative Medicines Canada, the national trade association representing our country's innovative pharmaceutical companies, created the Health Research Foundation. Much to its credit, IMC has stood fast to its founding principles to support the research that demonstrates the highest standards of scientific excellence, to improve patient outcomes and sustainable healthcare, to leverage expertise through strategic partnerships, and to underscore the value of health research in Canada. Since 1964, close to 1,700 researchers have been granted more than $30 million in funding. This sizable investment has served as a lifeline for Canadian health research. It has inspired and supported groundbreaking initiatives that have enriched the lives of all Canadians. Once again this year, we've put together a program that reflects our mandate and values through informative presentations, engaging dialogue, and the bestowment of our signature honors. As you might remember, last year, we announced the creation of a chair in Pandemic Preparedness research. That chair was awarded to Dr. Srinivas Murthy, Clinical Associate Professor in the Department of Pediatrics at the University of British Columbia, and a critical care specialist at the BC Children's Hospital. This year, Dr. Murthy will share lessons learned from the fight against the pandemic and elaborate on how those lessons can be carried over into standard practice. Following Dr. Murthy, we will present the Health Research Foundation Fellowship in Health Systems Resilience. This new fellowship is devoted to the examination of factors that enhance or undermine the resilience of our health system. Its purpose is to help strengthen the system's capacity to accommodate and adapt to shocks while maintaining and improving performance. A panel discussion with thought leaders from industry, government, and the patient community will follow on how northern, rural, and remote health systems can better generate knowledge for decision and policy making during public health emergencies and ongoing health systems transformation. We will then present the Health Research Foundation Medal of Honor. The Medal of Honor is a long-standing distinction acknowledging those whose influence on public health policy has had an international impact. The recipient will receive $20,000 to donate to the Canadian research-based academic institution of his or her choice. But before we get to all of that, I'd like to introduce the President of Innovative Medicines Canada, Ms. Pamela Frelagh. Throughout her distinguished career, Ms. Frelagh has proved an exemplary advocate for positive change in the Canadian health sector, someone who has long honored the right of all Canadians to have ready access to the medicines that they need, when they need them, a major mandate of Innovative Medicines Canada.
Merci Mel pour votre aimable présentation et bonjour à tous et à toutes. I'm very pleased to be here with you today on behalf of Innovative Medicines Canada to support the important work that the Health Research Foundation enables. A vital part of HRF's activities is to reflect and respond to both occurring and emerging health challenges and opportunities. For almost 2 years, the world has endured the largest health crisis of many generations. This time last year, it was still hard to imagine that we might have vaccines and treatments bringing us closer to the end of the pandemic. And while there is still work to do in response to COVID-19, pandemic preparedness insights from Dr. Murthy and the Fellowship in Health Systems Resilience are part of future-proofing Canada for all Canadians. It's one of the reasons why I'm looking forward to listening to the panel discussion on northern, rural, and remote health systems today. Indeed, Canada has the opportunity to draw on lessons and solutions from across health systems and regions. And this is central to strengthening research and innovation in the life sciences sector writ large. It's why Canada's innovative pharmaceutical industry works with academia, regulators, patient organizations, governments, and all other partners. Together, we can leverage our collective resources and strengths in AI, quality clinical trials, talent, and post-secondary programs, amongst others. We believe in strengthening Canadian innovation and health research, and we value the world-class researchers and facilities that exist in this country. Advancing and championing this work is what makes today's event so important. On that note, I look forward to hearing more from our distinguished speakers here today about how we, as a group, can continue to enhance the health and well-being of all Canadians in meaningful ways. Thank you. Merci beaucoup.
Thank you, Pamela. As you might remember, last year, Innovative Medicines Canada announced the creation of a chair in pandemic preparedness research. This, of course, was necessitated by the immense challenge brought on by COVID-19, a challenge that is yet to run its course. Investing in a research chair is one of the many ways the member companies of IMC contribute to the fight against the ongoing crisis and help to promote pandemic-related research in Canada. The research chair is held by Dr. Srinivas Murthy, Clinical Associate Professor in the Department of Pediatrics at the University of British Columbia and Critical Care Specialist at the BC Children's Hospital. Dr. Murthy's vision is to establish Canada as a leader in adaptive, integrated clinical trials in hospitalized patients for the purpose of rapid knowledge generation for both the current crisis and future outbreaks. The main objectives of Dr. Murthy's research are to expand a national platform for sharing data from patients hospitalized with severe acute respiratory infections and to develop a research infrastructure for rapid clinical trials. In his role as research chair, he's also assessing barriers to and facilitators of implementation of pandemic-specific clinical trials in Canada. Last year, Dr. Murthy introduced us to his work creating a national data sharing platform on patients with severe acute respiratory infections, as well as his effort to create a research infrastructure for rapid clinical trials. He also discussed his plan for a priority setting exercise for severe acute respiratory infection research and to establish a framework for the generation of critical questions relating to response to future pandemics. This morning, Dr. Murthy will provide us with an update on year one of his research, where we are at today, and what the future may hold as we emerge from the battle against COVID-19. Dr. Murthy, over to you.
Thanks, Mel, for that very kind introduction, and thank you to everybody. And mostly thank you to the Health Research Foundation and Innovative Medicines Canada, who have provided me the opportunity to sort of push this work forward over these past number of months. As I'm sure everybody can appreciate, it's been an exceptionally busy time for all of us, and particularly those in the clinical and clinical research community, as we've learned quite a bit about what works, quite a bit about what doesn't work, and thinking about what kind of system we want in Canada and the world for the future. So I'm going to talk for the next 20 odd minutes about these learnings from COVID-19, 23 months in. I gave a talk similar to this last year at this meeting, and I had the 11 months in, so I kept the same title slide for continuity's sake, but obviously this is going to be a wholly new, wholly different talk about how things have gone over these past number of months and what we've learned. My name is Srinivas Murthy. I'm at the University of British Columbia. So mostly we have these thesis statements, namely, what have we learned about the barriers to creating a health system here in Canada that can learn, adapt, and respond to emergencies and bring innovation to patients. It's a complicated thesis and a complicated idea, and trying to unpack each of those things is what we're working on with our large team of collaborators around the country. First thing is the health system. And I think everyone in Canada especially can appreciate that we don't really have a health system in Canada. We have multiple health systems in Canada. And this is just number of deaths by province during this pandemic due to COVID-19 from the agency, showing huge discrepancies across borders, across provinces about how the response to COVID-19 has gone. This is not new news, but this speaks to the complexity of how we want to think about system change in Canada to better learn, adapt, and respond to health emergencies, incorporating this specific complexity that is the Canadian health system, or systems, as it were. Second thing is learn, adapt, and respond. And everybody can interpret that component of our pandemic response and our clinical health system response in a different way. I love putting this slide up, highlighting that perspective is everything, and how you look at a problem and what your possible solutions are to that problem almost entirely come from which direction you are looking at something from. And so when we think about how to learn, adapt, and respond to a problem, we have to understand who we are speaking with and who is coming at us with the problem itself. And so when we think about Canada itself and how we learned, adapt, and responded to it, I think most of us will appreciate that most of the main findings of clinical importance or public health importance that have defined policy during this pandemic have emerged from places outside of Canada, whether that's vaccine studies, whether that's therapeutic studies, and so on. What we have learned is that most of the data is a global data set that's being integrated into Canadian practice. Ideally, there would be a more harmonized and mutually coordinated approach where data that's produced in Canada is used in Canada, and data that's produced in Canada informs the rest of the world. And so that learn, adapt, and respond component, the learning ideally happens within these borders so that Canadians can best appreciate and best incorporate them into their practice. And then innovation. And I think bringing innovation to patients is what we all want. And it's just a matter of how we define innovation. And there's lots of ways of doing it. You could say that receiving a dose of COVID vaccine is a reflection of how we incorporate innovation into practice. I'm not going to get into specifics of how that works. That's obviously a complicated idea. As you see in the G7, Canada is doing quite well in terms of proportions who received at least one dose. This is data from early November. I'm not going to speak to the regulatory approaches either. It's well documented and described. This is pre-pandemic data for oncologic agents about the delays that Health Canada has about novel products compared to other regulatory agencies. That's also beyond the scope of this talk. What we will talk about is sort of integrating clinical trial infrastructure and clinical research within the pandemic response, and then within the response to other health emergencies going forward. This is an NIH website about how to find clinical trials, for example. There's been hundreds and hundreds and hundreds and thousands of clinical trials for prevention, for therapeutics, for diagnosis of COVID-19. And I think it's been a challenge for everybody to weed through all of those complexities, both at the trial implementation perspective and also at the trial information synthesis perspective. And what this sort of mess of information has led to is chaos, arguably, both at the bedside and at the policy level about how to integrate new information and how to prioritize which study to do across different frameworks. There's a classic Doug Altman quote. Doug Altman is a famous statistician in our clinical trial world who says that we need less research, better research, and research done for the right reasons. And this is something that the clinical trialist in me always takes to heart, as to say that we need high quality stuff that defines practice and changes what we do in clinical care. But less, better, and done for the right reasons are complicated ideas. And we'll sort of unpack those going forward. This is a slide I always like to show with every pandemic research talk about, say, 5 years ago, before this pandemic, we made this figure saying ideally a clinical research response happens at the very beginning of an outbreak so that you are able to reduce the burden of that outbreak so that you can improve the actual public health and overall response to an outbreak. Typically with previous outbreaks, the research response has happened very late. We want that to be at the very beginning. For COVID-19, it's happened. There has been a whole number of clinical trials as discussed. Their coordination could have been optimized. And so what have we learned about the barriers to creating a health system that can learn, adapt, and respond to emergencies and bring innovation to patients. And we've learned that we really need randomization. And the idea that randomization is the data that actually improves clinical care has been sort of well documented, specifically from our vaccine information, but also from our therapeutics perspective. So what do patients, providers, and policymakers want from their clinical trial systems? And how do we make that happen? And this is sort of where we've been looking at things over the past number of months, specifically related to the pandemic, but lessons applied after the pandemic as well. And I think the first lesson that we have learned is that it needs to be useful, the clinical trial system itself. It needs to be useful for patients, and it needs to be useful for health systems. And those things aren't always the same, and we need to incorporate those perspectives as we design these clinical trial systems. And so what we've done is we've set up this multinational patient group and have gone through these formal prioritization exercises and qualitative work to really examine what patients around the world and in Canada want from clinical trials specific to the pandemic, but the lessons can apply more broadly. And so the question of why would a patient participate in clinical trials? This is well-trodden territory, but specific to this pandemic, the overwhelming response is I want the results to be useful to the world. And that feeling of need to participate in research almost exclusively for the benefit of others around the world in a global pandemic is quite heartening, arguably, and useful information for clinical trialists, clinical trial systems, to understand how we can best get information and use the information from patients for people around the world. What should the clinical trial help with? And so people want results to be useful, but what are the things that people actually care about? i.e. what outcomes are important to you for an acute infection. And so the James Lind Alliance is a priority setting process whereby you ask these patient groups and stakeholders about what's important in a specific context. And it's really sort of a methodological approach to understand how decisions are made across groups and how priorities are set. And really the three things that patients care about the most are whether or not they, after an acute infection, whether or not they need to go to the hospital and stay in the hospital. That's a major implication for their lives, for their quality of life, for the burden of disease, and so on. Obviously, they care about whether they live or die. They don't really care about when. They don't care if it's 28-day mortality or 90-day mortality or whatever, because from their perspective, that does not make a difference. They care about whether they live or die. And they really care also about long-term function, especially with COVID, as the long COVID agenda and the long COVID idea builds. This idea of what the impact of any specific intervention, whether it's a prevention intervention or a therapeutic intervention, and its impact on long-term function needs to be incorporated into our processes. And so when we think about a clinical trial system for a pandemic or a health emergency, and when we think about it for a non-health emergency and any other acute infection, framing it in these three sort of big picture items, which patients really want to know about and want those results useful for the world, really needs to form the core of our clinical trial system to learn, adapt, and respond to health emergencies. What do you want from a clinical trial? And then why are they participating once again? I want to know also that what the results are. And this is a sort of a more long-standing, well-trodden feature of clinical trials and reporting results to participants. And they've often noticed that they haven't always been notified of the results and only hear about it in press releases or after the fact in news reports. And participants really want to be involved in the process all the way through. We want to know what the results are at the earliest possible opportunity. And so our task coming forward in this part of it is to set up that clinical trial results reporting infrastructure to patients for the clinical trials across our clinical trial networks in Canada and in other places. It's a complicated idea because it does involve making sure that the results are valid, relevant, and useful and understandable for each individual patient. Lesson 2 we've learned is to keep things simple. From a clinical trials system. And I spoke about this last year at this meeting about how Canada can better embed randomized trials into clinical care. And I always like to highlight the American and the British examples and how they are very different in terms of how they've approached the clinical research infrastructure. I'll highlight an article in JAMA from earlier in this year by some close colleagues about lessons from for the US clinical research enterprises. And their main challenges that they highlight, number one, are the structure of the clinical research enterprise, and two, the interface between clinical research and clinical care. And these are challenges that exist without a doubt in Canada itself. In Canada, we do have silos, silos between clinical and research, silos across research institutions across our country, and across clinical institutions across our country, and across industry and clinical care. And all of these silos really tend to speak at the same tables and don't get involved in the same conversations. And that siloing leads to all of the complexities that has resulted in somewhat of a fragmented approach to clinical research infrastructure. For example, a clinical trial that I am running or partially running with a large number of collaborators, we have data in terms of the numbers of steps required for a study to be operationalized and ready to go during a pandemic. And the median days from protocol being available and sent to a participating site to a first patient being enrolled is about 160 days. And so regardless of whether you are fast at the front end at writing and designing and doing the statistical process of getting a trial protocolized, getting a site operational because of the contract RUBs and other regulatory requirements often requires a large number of days. And this harmonization process, we see lots of opportunities to see how things work in a multi-jurisdictional. I'm going to put this quote up from that JAMA article because I think it really highlights some of our challenges in Canada as well that we're trying to unpack. The clinical research enterprise is set up like a marketplace with researchers competing against each other, using the appeal of their ideas, their reputation, and their experience to convince funders and colleagues to support and recruit patients. Trials are difficult to execute, become zero-sum games, and that if a study team sets up a trial to answer one question, oftentimes there is little ability to support a second trial. And particularly with a zero-sum game of fixed number of patients with one disease, i.e. COVID-19, we really need to think differently about how these trials are set up and how these trials are coordinated. And so our next task, and this is something that we've gotten CIHR funding for, I'm thankful to the HRF and the IMC for putting together some of the foundations for some of this work, is to set up a perpetual platform trial infrastructure across Canadian institutions. This is no small task and no small feat, and this is something we're working very hard on right now. I took that little kid pushing a sumo wrestler deliberately because there's a lot of barriers to get this operational. But we do have the statistical expertise and we do have the technical expertise, and working through the operational processes to set up a perpetual platform trial for many different clinical conditions that leads to great numbers of operational efficiencies as well as statistical efficiencies is our goal. And we have we're always looking for industry partners as we think about how to build this going forward. Lesson 3, figure out what works and what does not work with research collaborators. Because remember, when you're running clinical trials across a number of places, the collaborators that you're working with will decide whether your trial lives or dies. And so you really need to figure out what works and what does not work. And so we have an ongoing process evaluation and focus groups and qualitative work that's happening across Canadian institutions, both in outpatients and inpatient settings, to determine what works from a clinical trial, what makes you feel engaged, what makes you feel like you're part of a team, and what makes you really want to recruit patients. And there's the two large lessons of one, institution, which brings staff in and really keeps the momentum of clinical trials going. And two, it's really engagement and feeling like you're part of a clinical team and having those results be useful for the patients you are caring for. And I think that fundamental relationship of utility of the results really comes out of our process evaluations and qualitative. We ask nurses, we're asking doctors, we're asking REBs, we're asking research institutes what works and what doesn't work. We have qualitative and quantitative analyses and a huge amount of rich data that we're continuing to unpack and inform to federal policymakers and provincial policymakers about how to integrate clinical research into practice. One thing that always comes up is the consent documentation, and specifically from the research coordinators and nurses perspective, is the length and breadth of each individual consent document, and how these are some choice quotes that people have come out with, both from a patient and coordinator perspective, and that leads to specific policy recommendations that we can make to our ethics boards and to our sort of governing organizations in Canada. Formal reports from this process are in process. Next task, obviously, is synthesize this risk assessment. And lesson 4, I think, and lesson 4 is something that I think we really want to highlight, is that a lot of these challenges that we have come up with and identified through this past 18 or 23 months are directly related to policy that exists in Canada, both in provincial policy, institutional policy, and federal policy. And I think one of the things that we have learned is that part of our jobs as researchers, as individuals who are invested in making sure patients get the best possible care, is to advocate for that policy change. And so, like, when we think about different trial systems and how, say, the UK has a coordinated system across their hospital infrastructure, and how Canada can sort of learn those lessons compared to places like the United States, where it's a bit more of a user and chaotic approach to things. We have received funding from CIHR to develop this national clinical trials network to address the COVID-19 pandemic, but using a lot of these lessons and addressing them and sort of building that infrastructure and building that policy recommendation set so that we can move forward for the next pandemic and for the next health emergency to better have a response to bring innovation to patients so that we can learn, adapt, and respond. We have advocated at the federal level, and we were grateful to see at the last budget in the spring a significant boost for funding for biomanufacturing and clinical trials, and specifically a clinical trials fund that's housed within CIHR, which is quite exciting to see. And we hope to see and be engaged with that process going forward. There is a Health Canada Clinical Trials Modernization initiative that we have actively advocated for, and I think that's part of the process that we will sort of continue to engage with our policymakers on, because I think from a policy perspective, making sure that we modernize our regulatory framework to that so that we can optimize learning and adapting in health emergencies would be the goal. And then from a research ethics perspective, there's a new proposed guidance for multi-jurisdictional research to harmonize things as much as possible so that we can streamline clinical research ethics processes for these types of research. And we have provided advocacy language there as well. And so while we have actual findings from a lot of our work, making sure that those findings are translated to the policymakers who are making these decisions about how to improve the clinical trial system in Canada is without a doubt part of this work. And so how can Canada take the efficiencies developed from this crisis to bring innovation to patients? I think these lessons, are important across the board. I will highlight that Canadian federal, provincial, territorial funding of universal healthcare has this very uncertain, fraught history and an uncertain future, and so remains complex and remains at the core of much of this work. Continue to sort of advocate for those necessary changes to make sure that clinical research is not forgotten about in this process. But first, I think the first sort of main process that we've learned is that we really need to break down these silos, the silos across institutions, the silos across provinces, and the silos across researchers in clinical care and researchers and industry. I think we need to randomize, and I think we learned that so much during this pandemic, that the importance of randomized evidence to inform clinical care cannot be understated, as we've sort of gone down rabbit holes already without that randomization evidence and it being difficult to pull yourself back from. And then third, that research and care bridge. We really want those things to be merged as much as possible so that clinicians around the country and practitioners around the country know the importance of research and know that the culture of research needs to be embedded within care and not seen as a separate silo. And so we have ongoing work across hospitals to make sure that those conversations are happening and that we make sure that we continue to advocate for this. So I'm going to stop there and say that Canada really has a long way to go to have a health system to be ready for the next pandemic with innovation and research. we need multiple perspectives. We need perspectives from patients, perspectives from policymakers, perspectives from research operators to ensure the optimal changes are made. And this is a policy and system change to be implemented. And I think everyone in this audience probably can speak to some of their challenges that they've had. And I think pushing forward on that policy agenda to make sure that we get the necessary things for the next pandemic, ideally not for quite a long time. And so thank you, and thank you to Mel for that introduction. I'm going to hand it back over to him, and hopefully everyone enjoys their day at this session. Take care.
Now it is my pleasure to introduce the recipient of the Health Research Foundation Fellowship in Health Systems Resilience. This new fellowship is part of the HRF's ongoing commitment to invest in academic centers across Canada that focus on innovative, leading-edge research. With this fellowship, we undertook specifically to fund research designed to enhance the resilience of Canada's health systems. As we all know, the COVID-19 pandemic has highlighted significant and persistent healthcare inequities in Canada. Underserved communities and health systems, like those in northern, rural, and remote settings, have struggled to meet the needs of communities. The barriers are many and varied: limited infrastructure and health workforce, urban-centric research and policy, and unequal distribution of resources, such as vaccines and personal protective equipment. These barriers are amplified by significant geographic distance between communities, disproportionate investment in rural research, and the siloed efforts of municipalities, health systems, and academia. Issues such as these call for scrutiny, informed action, and the kind of dedication provided by this year's fellowship recipient, Dr. Brianne Wood. Dr. Wood is the inaugural Joint Social Accountability and Learning Health Systems Associate Scientist in a partnership that brings together the Northern Ontario School of Medicine, the Thunder Bay Regional Health Sciences Centre, and the Thunder Bay Regional Health Research Institute. She also serves as the director of North-H, the NOSM Research Toward Health Hub, a practice-based research network for primary healthcare providers. With a PhD in epidemiology from the University of Ottawa, Dr. Wood has expertise in integrated knowledge translation and mixed methods research. She also has applied experience from her work as a health systems epidemiologist in Northern Ontario. Her areas of focus include health equity impact assessments, health system performance measurement, and primary healthcare capacity specific to northern, rural, and remote contexts. Her research program will investigate how northern, rural, and remote communities and health systems can better generate and translate knowledge for decision-making and policy during public health emergencies and ongoing health system transformation. Her vision is to improve health and healthcare using a collaborative research approach to understand how northern, rural, and remote health systems learn. Specifically, she will work with health and education stakeholders and Northern Ontario community members and patients to test a framework for a learning health system that is socially accountable. This system will integrate education, research, and health service resources and initiatives to create meaningful impacts for local communities. Dr. Wood's research program will outline approaches to rapid research or improvement in rural settings to improve local decision-making and contribute robust evidence to provincial and national policies. Her research will be complemented by an intervention to strengthen analytic and evaluation capacity in the Northern Ontario health workforce. With a skilled workforce and an understanding of how to enable a socially accountable learning health system, her research program will help northern, rural, and remote health systems better meet the needs of their communities and of their health workforce. Dr. Wood was selected from among several very impressive proposals from researchers all across the country by the Foundation's Fellowship Selection Committee, made up of leading Canadian life sciences experts. Her research will be supported by $450,000 in funding over 3 years. On behalf of the Health Research Foundation and Innovative Medicines Canada, congratulations, Dr. Wood. We look forward to your presentation and the panel discussion that will follow.
Hi, everyone. I am thrilled to be here and grateful for the opportunity as the Health Systems Resilience Fellow from the Health Research Foundation of Canada. My presentation today is talking about my research program, which is socially accountable learning health systems in northern, rural, and remote contexts. So I'm Dr. Brianne Wood. I'm an associate scientist at the Northern Ontario School of Medicine and the Thunder Bay Regional Health Sciences Centre. And so today I'm calling in from Thunder Bay, Ontario, the traditional territories of the Anishinaabe and Métis of the Robinson Superior Treaty. And I'd like to acknowledge that we're all on the traditional and unceded territories of First Nations, Inuit, and Métis people across Turtle Island. And so I'd just like to acknowledge the land and the resilience of Indigenous peoples in Canada. And think about this as we go through my presentation and we talk about decolonial futures and strengthening resilience and what can we learn from Indigenous knowledges and communities. So in the next little while, I'm going to give you an overview of why I'm here today, what am I hoping to accomplish with my research program, and the so what. So I'll give you a little bit of background into northern, rural, remote health and healthcare. What do I mean by northern, rural, and remote? And then I'll dig a little bit deeper into some of the jargon that I use, some of the buzzwords and catchphrases, social accountability in learning health systems, and how does this relate to resilience? And then I'll give you some insight into what I've proposed to do with the timeline across the 3 years. And then, of course, the so what, why should we care? So northern, rural, remote, we hear these phrases a lot. And we often think about them in terms of shared inequities, but really there are a lot of different understandings of what it means to be northern and what it means to be rural. And I'd like to draw your attention to a recently published book by my colleagues at Lakehead University here in Thunder Bay that published about this topic specifically. So certainly something to check out. But when we think about northern and remote and isolated, it's actually a relative term. You know, we hear people in Toronto talking we the North and celebrating the Raptors, but we're used to different understandings and conceptualizations of that. And so today when I talk about northern, I'm really referring to not only Canada's north, so thinking of the Northern Territories, Nunavut, Yukon, Northwest Territories, but also the provincial north, like where I am here in Thunder Bay. And again, this is a really important factor. Although we talk about shared experiences in terms of access to healthcare, different health experiences, there is a lot of heterogeneity across northern, rural, remote, isolated communities as well. And so certainly I'm not trying to imply that there's only one experience and that my experiences speak to that of others, but I think it's important that we realize that these shared experiences, especially of inequities, are something that we can address specifically with health system resilience. So COVID-19, there was a significant protective factor initially for northern, rural, and remote communities and populations because of our relative isolation. However, the social and health inequities ended up catching up with us. I'm thinking in Thunder Bay, you know, we were relatively good in wave one, and then some outstanding issues of homelessness and crowded housing ended up seeing that we became one of the hotspots in Canada. And certainly Indigenous communities who also share the same isolation, but also impacted by the legacy of colonialism, have experienced COVID in a really dramatic way with severe morbidity and mortality. And we know that going forward, even in the recent months with the Delta variant, that northern, rural, and remote populations and communities still seem to bear the brunt of this infectious disease. And so We saw a few months ago, or actually even a few weeks ago, that in Alberta, some vaccine hesitancy that tends to be more prevalent in rural and isolated regions led to more increased morbidity with COVID-19. And so because of these different experiences, we're going to have ongoing health and healthcare challenges moving forward. And again, I just took this screenshot of the COVID-19 experiences last week, and coming back to Canada's north and the provincial norths, we're again seeing the burden of the illness heavily concentrated in some of those more isolated regions. And so what are some of these shared experiences that I refer to? So what are the characteristics of northern, rural, and remote populations in terms of health and healthcare? So typically the populations tend to be older on average, have higher rates of high-risk health behaviors, multi-morbidity, and socioeconomic conditions that are less desirable than perhaps more urban centers. And something that's really stood out, particularly with the pandemic, is the lack of reliable broadband infrastructure. And so as the healthcare system is transitioning to a perhaps not entirely virtual, but a predominantly virtual care delivery system, this is inequitably and disproportionately affecting northern, rural, and remote populations. And as we heard in the introduction, these urban-centric policies, particularly for health and social decisions, tend to be made by provincial and federal level policymakers. And so the needs of northern, rural, and remote populations actually get watered down because we don't have the voices at those tables. And something that might sound familiar is also the health professionals and the health workforce. So certainly across Canada, we know that the workforce is burnt out. They have been working nonstop since the beginning of the pandemic. And that is so true in northern, rural, and remote communities who already experienced workforce shortages. And so with the roles of the health professionals expanding significantly during the pandemic, having to take on and provide care in other settings, as well as take on administrative roles and sit at different tables, we are experiencing crises in northern, rural, and remote healthcare systems. And as a researcher, this is something that I feel that I can speak to, the fragmented knowledge generation and sharing. So we often colloquially talk about the academic ivory tower. Well, and sometimes the knowledge generated there, however important it may be, might not get to the right knowledge users in communities and municipalities in the healthcare system. And similarly, knowledge generated in communities in the health system doesn't necessarily work with the academic structure. So there's some room for improvement. And so Northern Ontario, which is where I'm calling in from, where I'm very familiar with our context. And so again, realizing that this is not the experiences of some of the other northern, rural, and remote, but there might be some bits and pieces that are familiar. So we do have unique population health as included in the image in the bottom left corner. The life expectancy for those in Northwestern Ontario is around 2 years younger for females and 2.5 years younger for males. And over the past 20 years, we have seen the socioeconomic gap between those in a lower socioeconomic class and those in the high socioeconomic class, their health differences getting smaller. And that disappearing of the gap has been less for people in Northern Ontario. So we know that there's something different in terms of our population health. And a lot of that might have to do with our access to health care. So we actually have quite a few different models of care delivery and funding, and sometimes it's not optimally set up to serve the needs of northern, rural, and remote communities. And of course, I spoke to the healthcare providers and the health workforce shortages that we have experienced in the last slide, but that also translates to a data and analytics capacity. So right now, if we want to be able to better generate knowledge, locally to inform decisions and have that evidence-informed decision-making and practice model that is so desirable, we don't have the capacity in the workforce right now to mobilize that structure. So there's a little bit more that can be done in terms of how could we build this sort of system learning. Now, I've often focused, and perhaps to this point in the presentation, really focused on the inequities, but I also really want to talk about the strengths of Northern, rural, and remote communities, and specifically in Northern Ontario. The Northern Ontario School of Medicine was created with a social accountability mandate, meaning that it has committed to, in its mandate, to serve the needs of the people of Northern Ontario and develop a fit-for-purpose health workforce. And of course, if you speak to anyone living up here, there is a certain pride and an engagement with the different systems and organizations and people that is really incredible and certainly contributes to the existing resilience in the communities up here. So to summarize some of the main ideas that really generated this proposal. So Northern, rural, and remote communities experienced disproportionate health and healthcare inequities during the pandemic. However, it is heterogeneous and we can't necessarily generalize across this subgroup of the Canadian population. We also realized that becoming a learning health system, or being a learning health system, so a system that can rapidly generate and translate information into practice, that's going to be critical. So really mobilizing or operationalizing that evidence-informed decision-making, that is important. Now, integrating both of those challenges, we know that because of these differences, Northern, rural, and remote learning health systems are going to have different infrastructure and data challenges and or different resources, and they need to have their voices amplified at the provincial and national levels so that policies can actually adequately reflect what our needs are. So this is really exciting because now we have such an opportunity to create lasting impact, to reduce health inequities. And we can do that by contextualizing and prioritizing knowledge that matters to us. So what we can do is we can create a learning health system that prioritizes health equity. That's true within Northern, rural, and remote communities and across Canada as well. So now I'm going to dig in to what do I mean by some of these concepts. So learning health systems has increased in terms of use in our political dictionaries, as well as in the research world, has increased exponentially in the past 10 years or so. And so this slide presents a couple of different models that are being used. And I've also outlined some of the key pieces. So in terms of the structures that contribute to a learning health system, we know that people, collaborations, and partnerships are the foundation of our health system. But to be able to generate the right knowledge, the appropriate data infrastructure needs to be there, as well as a shared vision to operationalize this kind of system learning. Of course, having the right resources to do that is going to help as well. Then the meat and potatoes of learning health systems is really in the learning cycles or the processes. And so we often think about the learning cycles in a health system as 3 different stages. There's the practice to data, so collecting data in everyday activities. There's the knowledge management cycle, which is analyzing that data and turning it into useful information. And then something that I'm passionate about with a background in knowledge translation is the knowledge to action, or the change management cycle. How do we then apply that knowledge to create change in our health system? And something that I'm hoping to focus on with this research program is actually a gap in the science. And there hasn't been a lot of investigation into the outcomes of such a system, which is funny because that's exactly what this model aims to do, is improve and create value in existing health systems. And so I've identified on this slide what is known as the quadruple aim. So improved population health, improved patient experience, improved healthcare sustainability in terms of cost effectiveness, and then improved staff and workforce satisfaction or provider experience. But of course, what is most important, I think, going forward, and again, what was highlighted in the pandemic, is the need that health equity and justice underscore all of this. And so let me introduce to you social accountability. So I was just introduced to this in the last couple of years, but it's already a concept quite familiar in the health professional education world. And ultimately, the idea is that health professional education specialists and stakeholders in the health system collaborate to respond to the priority health needs of a population, and specifically of the population that they serve. Additionally, there is a mandate to advocate for those who are marginalized or underserved. And so similar to the learning health system, there are lots of different frameworks that conceptualize social accountability and talk about its practice, but there are a couple key pieces. And again, it's about responding to the priority health needs locally. So contextualizing one's activities and focusing on outcomes. And we can also think about social accountability. I think it's an avocado on the screen. And really what that is indicating is that this idea of responsibility and accountability occurs at different levels. So there's the level of an individual, of an organization, and of a system. And so during my postdoctoral fellowship at the Northern Ontario School of Medicine, I was really interested in bringing these two frameworks together because ultimately what my team, as well as some colleagues at the University of Ottawa, suggested is that we need these two concepts to integrate to be able to achieve what both frameworks aim to achieve. And so what social accountability needs is the ideas and structures behind learning systems to be able to achieve their health equity goals. And what learning health systems needs are that focus on outcomes. And so the two different frameworks are actually quite synergistic if we're able to structure them and operationalize them accordingly. And so this image on the screen here is one of my first drafts of an integrated socially accountable learning health system framework. And it's a busy image. And so I'll just draw your attention to a few pieces. In the center, we have what the social accountability outcome impact goals are. We want accountabilities, which happens through partnerships and co-produced activities. And ultimately, we want equity, justice, and fairness. And so what you'll also note is that we have the different representation of groups, research, education, health services, and community also present in a socially accountable learning health system framework. And then the other piece I think that is really important is that we're looking at those learning cycles that I spoke about and actually wanting to assess how are we transitioning between those cycles? Are we actually creating activities, taking action on what we've said that we want to do? So that's transition one. Transition two is coming back to that outcomes piece. How are the activities that we're participating in and that we're intentionally designing, how are they changing the outcomes that matter locally? And then the cycle piece, coming back to continuous improvement, is how are the outcomes and the knowledge that we generated in these learning cycles, how can we use that again to continuously improve the system? So that's a little bit of background into the work that I've done recently, and hopefully that will give me a starting point of where I'm going to go with this research in the next 3 years. And as mentioned in my introduction, which I'm very grateful for, my goal is to improve the health and healthcare in northern, rural, and remote settings. And ultimately, I hope to do that by not only understanding, so investigating and creating knowledge, but also building a socially accountable learning health system. In this slide, I'm communicating the timeline and what I hope to accomplish over the next 3 years. And this slide is really focused on outputs, but I think that we can look at it year by year and what can be accomplished. And in year one, I think the focus will be on building and nurturing relationships. And so to accomplish that, it's going to be really important to hire the right people, which is an opportunity that is afforded to me by this fellowship. And so in terms of the research objectives, for objective 1, to refine and implement the impact framework, we'll be looking at system mapping and really tracing the context, mechanisms, and outcomes that are important for a socially accountable learning health system. And another piece is working with the stakeholders and the networks who I have connections with, building relationships and identifying the gaps that we have in the health workforce related to learning health systems. And then in year two is about doing. It's about doing the work and being a learning health system. So in terms of the impact framework, what I would like to do is I want to report back what is the progress towards a socially accountable learning health system of the existing health system in Northern Ontario. We'll be looking at primary healthcare data to understand mental health and preventative health services use across the COVID-19 timeline. And of course, we'll also be implementing the capacity building program. And then year 3 is really about doing. Is really about sharing. So what we'll be doing is we'll be sharing the results of the impact framework back with the local knowledge users, as well as the broader research and knowledge user community who are interested in northern, rural, and remote health and healthcare. We'll be sharing our findings related to the primary healthcare usage with different stakeholders as well. And then we'll be looking to refine the educational program. And as I said, sort of year 1 is really about building and nurturing relationships. And so I've included this slide to highlight those networks and relationships that I have and that I'll be looking to leverage throughout the next 3 years to be able to share the knowledge, to better generate the knowledge, and to build capacity in socially accountable learning health systems. And so the final part of my presentation is the so what? Why is this important and whose resilience are we strengthening? And so this is a very busy slide, but ultimately I just want to communicate that the potential for impacts with this research program vary across stakeholders. I mean, Northern Ontario, you know, where I live and who the people that I work with, I'm really excited about the opportunity to improve the data infrastructure and the health workforce and analytic capacity to become a learning health system. And this will strengthen the resilience for ongoing system transformation that requires local knowledge. And of course, this work and what we learn is going to be important for other northern, rural, and remote settings and health systems, because we'll be starting to generate those networks and relationships across different institutions, organizations, and sectors. And so what we can share are strategies, accountabilities, and different ways of doing with those stakeholders. This is going to be important for amplifying the needs of northern, rural, and remote health systems and communities to provincial and national level stakeholders, which is a gap that I'm very happy to be able to address. Scientists are going to be able to benefit from this research program as well, because now we'll actually have some evidence on the outcomes of a learning health system. So is it achieving what the model set out to achieve? And of course, the opportunity to build capacity in the existing workforce, as well as up and comers in the academic world, is really exciting. And that's something that I'm specifically addressing with Objective 3. And I think I would be remiss if I didn't offer a bit of perspective in how will we know if we're achieving this. I've spoken a lot about evaluating impact, and I just wanted to give an impression that we have thought about ways to assess whether this research program achieves what it set out to achieve. And I've given some examples on this slide here. But ultimately what we're looking for is we're looking for what has been created locally or in Northern Ontario related to socially accountable learning health systems, and how have other policymakers, decision makers, healthcare organizations, how have they used the products that we've produced as part of this program. So to summarize, Northern, rural, and remote communities and health systems experienced COVID-19 very differently, but one common thread is that many inequities were enhanced and brought to the forefront. And we saw that one of the ways that we can combat this is by understanding what's going on locally and then applying that knowledge as well, not only locally, but also bringing those voices and amplifying that knowledge at provincial and federal tables. And so what I hope to do with my research program is take upon that idea of a socially accountable learning health system, and I want to understand it by researching it while also building it locally in Northern Ontario. And ultimately, it comes back to wanting to improve the health and healthcare in a meaningful way for Northern, rural, and remote communities and health systems, and specifically Northern Ontario. And so I do want to thank certainly the Health Research Foundation for the opportunity and for this amazing award. I'm very excited about pursuing this work. And then I'd like to thank my institutions as well, Thunder Bay Regional Health Sciences Centre, the Northern Ontario School of Medicine, and then the people in Northern Ontario who have already contributed to my work and been very supportive so far, and are happy to have their voices amplified. So I just want to say thank you.
Thank you. It's time to move on to our panel discussion. Our theme for this afternoon is how Northern, rural, and remote health systems can better generate knowledge for decision and policy making during public health and ongoing health systems transformation. I'd like to introduce our four distinguished panelists for today's session. The first panelist is no stranger to you, at least not anymore. It's Dr. Brianne Wood, recipient of the HRF Fellowship in Health Systems Resilience. Again, Dr. Wood is the inaugural Joint Social Accountability and Learning Health Systems Associate Scientist in a partnership between the Northern Ontario School of Medicine and the Thunder Bay Regional Health Sciences Centre and the Thunder Bay Regional Health Research Institute. Next on the panel, we have Dr. Suna Avshel, Executive Medical Director of Amgen Canada. Dr. Avshel is one of the women spearheading Amgen's Her Health First program, an educational campaign shedding light on some of the most pressing issues in the field of female health, including bone health, cardiovascular disease, and cancer. This campaign also addresses the many barriers to medical assistance for these conditions, including external influences such as COVID-19. Aussi, nous avons le Dr. Dominique Perry Bay, vice-président de la recherche du Conseil de recherche en sciences humaines du Canada. In this role, Dr. Perry Bay is responsible for developing the future direction of SSHRC's core research funding programs. In addition, she oversees the strategic direction and delivery of tri-agency programs and policies in collaboration with other federal research funding agencies. She also chairs the executive board of the Tri-Agency Grants Management Solution Initiative. And last but certainly not least, we have Martine Elias, Executive Director, Myeloma Canada. Ms. Elias is a recognized leader in patient advocacy. She has worked internationally on global patient advocacy and improved patient access to medications. She's a strong believer in ensuring the patient voice is included in all aspects of health policy decisions. And as a former patient, I thank you for that. Let me turn to a couple of questions that I'll pose to the whole panel. First of all, Brianne, you had this interesting quirk of having your internet seize up on you from time to time. And that's what you were talking about at that same moment. So it was like a self-referential experience, this sentence, no verb. And I'm just curious, to what extent do you anticipate that your research will disclose technology as a major barrier?
I think that's a great question, and I think that there are different technology pieces, you know, at different stages and points in the health system. So, I mean, in my presentation, I alluded to the need for good internet connection for virtual healthcare. So certainly patients accessing healthcare, that's a key consideration. I think of the learning health system and the need for data infrastructure. And currently right now in Northern Ontario, we have, I think the quote was 128 electronic medical records. So having integration of electronic medical records will help clinical point of care, is going to help health system planning, is going to help research. And then another piece, and this is again bringing up one of the themes I talked about in my presentation, is about amplifying the unique technology, digital health needs of northern, rural, and remote communities. But I'm also thinking specifically of First Nations communities. Data governance is a huge consideration and movement going forward. And with Indigenous data sovereignty, we need some really strong guidance and principles and guidelines to advance work in that area. So how do we move and advance a digital health strategy that responds and honors Indigenous data governance? So those are just a few pieces that I'm actively engaging with my research, but absolutely, I mean, that's the future of healthcare.
Dominique, Martine, or Suna, comment on technology?
I can comment on technology. Actually, I agree with Dr. Wood's assessments about the need to invest in information technology infrastructure that will support evidence-based assessment for access to medicine, integration and sharing of healthcare data, optimization and extension of healthcare. Because of their unique and insular dynamic, northern, rural, and remote health systems also are uniquely positioned to serve as a microcosms of underserved healthcare models. Data and technology infrastructure pilots can describe best outcome scenarios that can be applicable to many other Canadian environments.
Martine, I'm wondering if Brianne's talked and Suna have talked about technology and information technology particularly, but there's also the physical infrastructure of diagnostics and such. A comment?
For sure. I mean, technology is wonderful when it works, when we just experience. And it's really, you know, difficult to expect that technology is always going to be there and people are going to be able to use the technology. Think about, you know, patients who are sick, elderly cancer patients. I represent the myeloma community, which is, you know, cancer that affects the people over 60 and older, sometimes younger, but they don't have the know-how for the technology. I mean, you go through, you know, we started at the beginning of the pandemic doing our education sessions through Zoom, and oh my God, like it was difficult to get them to, you know, understand the technology, be not afraid of the technology. And so, you know, just we start from basics in engaging the patient community in using the technology. So those are issues that are broad from across, you know, the population, being you live in the north or you live in a large large center, but I think that's exasperated in the northern region for a number of reasons. One being that, access to the treatment center in northern region is also difficult. And sometimes you have to drive, 100, 120 kilometers to go for your cancer treatment. So at home treatment is always better. But can patients sort of continue in that level of driving and demand that is being placed on the patient, but also on the caregiver? I mean, I can't imagine having to drive twice a week for a treatment, 120 kilometers, and then or sometimes having to stay the night before at the cancer center. So the advance of, virtual is a no-brainer. It's really helpful if you can sort of bring the treatment to the bedside or to the home side of the patient. And then you add on to your whole, presentation, Dr. Wood, which was wonderful, all of the other issues around the Indigenous population, the underserved population, people who have less, access to care or knowledge. I mean, myeloma, for example, is a disease that affects a lot of the Black population. And we know that the socioeconomic factors of the Black population are not the same as that of the Caucasian population. So, I mean, I could go on about the issues, but, I think your research is really going to be helpful to understand and address how can we do better? I'll stop here for now.
Well, you can't do chemotherapy by telehealth.
True.
So yeah, right.
You can bring the nurse to the patient to
exactly
right. to the patient's home.
Yeah. Dominique, is technology the solution to our future?
It's even the solution for research. Before I make any comments, I just want to congratulate Dr. Wood for tackling that very challenging type of research, and I guess also the foundation for having the courage to support that kind of research, because it's a community-based, community-led research is definitely challenging, and I was really impressed with the preoccupation of measuring the outcomes of your research and reintroducing the results. That's a marvelous approach, and that's definitely something our organization, SHRC as we call it, the Social Sciences and Humanities Research Council, is at the core of the kind of research we're trying to support. Digital is becoming, absolutely everywhere. And during the pandemic, it was really observed that it became essential to all of the researchers, and it sort of transforming all the community-based research, which had a very different approach before COVID. And now it's after COVID, we launched a special call over the summer to trying to, I guess, take the positive out of the pandemic, and asking researchers if they had ideas to develop new methodologies of research based on digital, essentially to lead community-based research, and how we could support it. So we do expect that everything that's going to be put forward is going to be digital.
Good. There is a positive future here. I'm particularly interested in comparative analyses. And so, again, let me start with Dr. Wood. You make the point that you're going to focus on Northern Ontario, but that it has application to the rest of Northern, rural, and remote Canada. I'm just curious of the extent to which you think there are similarities, and what are the comparative dynamics, essentially, of Northern Ontario versus Northern Canada, and Northern Canada versus other international comparators? Are there lessons internationally here that we can take?
Great question, and certainly something that I do get on a lot of research proposals. But yeah, exactly. How is this important for others outside of Northern Ontario? And I think actually the other panelists have already spoken to one of the key pieces. We're looking with this research program to create contextualize, prioritize knowledge of an underserved community. And we're just calling that underserved, or we're specifically looking at an underserved community, the northern, rural, and remote communities, health systems, that population in that setting. But there are definitely methodological learnings for other underserved groups. And then I think there will be some specific findings too. I mean, as I communicated in one of the slides, there are some commonalities in terms of the population health of northern, rural, remote populations and of the healthcare delivery system. And again, the last question was really provided some insight into some of the challenges that are common across the different communities. So while I do focus in Northern Ontario, I mean, the connections that we bring, it will be about finding those similarities across Canada. You know, I'm thinking of the types of providers that we have, the way that health professional education directly feeds into the health workforce, addressing common population health issues. And luckily, I do have connections to some of the networks that can facilitate that. And I know the Northern Ontario School of Medicine has quite an international presence, again, focusing on health equity. And I think, again, that's sort of the common thread that will link us together and allow the knowledge to be generalizable. So it's this really interesting tension to contextualize important system learning knowledge for Northern Ontario, but to have it standardized in a way that's important for others as well. So it will be a tension that I'll have to negotiate, but I mean, others have been doing it for ages, and so I can learn from what's already been done.
Good. Suna, your Her Health First initiative, which is a corporate at Amgen. What do you see in terms of the international comparisons and similarities and differences?
I mean, first of all, we must accept that pandemic has exposed the fragility of the Canadian healthcare system. So maybe we are here talking about northern, rural, and remote health systems, but it's just at best we can say they are heterogeneously affected. So we need to really address the direct and indirect impacts of the pandemic. Gaps in care, especially preventive care, reduced our resilience to the shock of COVID-19. And this is, you can observe it everywhere, actually, in all country. So we need to take actions in the nationwide, countrywide. So about the other diseases or initiatives, actually Canadians' situation is not too much different than other countries. So we need to have access to the innovation, to the medicines fast. Now with the COVID, actually we started to talk about what is resilience. So how do you measure resilience? For many years, actually, we talked about sustainability. In healthcare, this has become synonymous with cost containment. What we have witnessed in recent months is that hyper-focus on cost containment over many years has left very little flexibility to respond to surges in demand arising from a pandemic, for example. So how do you measure resilience? And we can, if you remember, or we will all recall, the high visible measures of healthcare system throughout COVID-19 was not efficiency, sustainability, or cost. Rather, the measures we tracked and the measures that got the public attention were the incidence and prevalence of COVID, hospitalization from COVID, mortality, the timing of access to vaccines and therapeutics, and disruptions in care across the spectrum of chronic and acute diseases. Patients with cancer, such as multiple myeloma, and patients with osteoporosis are also waiting for new medicines, just as well we all waited desperately for COVID vaccines. And resilience must be measured by patient outcomes, the decreased prevalence and incidence numbers, reduced hospitalizations and death numbers. And I believe we can do a better job in Canada for at least this month. We are also talking and kind of recognizing increasing awareness about osteoporosis, and we can do better for our females over 50 years of age.
Martine, Suna raises the comparators in cancer. I used to be vice chair of the board of the Canadian Partnership Against Cancer, and the myeloma is not a Canadian disease. You must look at, and I know at CPAC they look at international comparisons. Do you have any comment on the international side of this?
Well, the impact on the myeloma community, and I would say the entire cancer population because of COVID has been very well sort of felt in a very hard way. I would say, if you think about diagnosis, many diagnoses have been delayed because patients either could not go for their screening testing, or they have symptoms, but they've been told to stay away from the hospital or not put pressure on the healthcare system. I think I've seen this in, European country. I sit with my international colleagues from Europe on a committee that looks at access to medicines and myeloma drugs, and the impact has been the same, I would say, across the world in the myeloma patient community. The biggest question for them and was immunization. Cancer is a disease of the immune system, more so in multiple myeloma. So your immune system is very much affected. So we were flying by the seat. Everybody was flying by the seat of the pants at the beginning. You were thinking, okay, well, is the vaccine going to work? What's going to be the protection, immune protection from the vaccine? How is it affecting, cancer patients, Crohn's disease patients, or lupus patients who have a weakened immune system? Nobody knew. And, when should you get the beauty of technology? So working from, from the patient's perspective, the impact of the immunization, not knowing when they could get their next vaccine, how much it's going to cover them, had a huge impact on their mental health. And that's been, worldwide.
That's an important addition. And I know, Brianne, you had a reference to mental health in one of your slides. And I think there's a dimension there that's particular to northern and rural and remote areas. By the way, I thought we were only 4 panelists, but apparently 5. Thanks, Martine. Dominique, you have an international network as well.
No, I didn't mute myself. Well, it's when you think about that question, of how you can replicate and how you can expand the impact of research at the international level, that's always a huge challenge of the research that we fund. That is very often, investigator-led, and of course, the community-based research has that opportunity to be more scalable to other situations when it is well documented and when it is well analyzed, when there's attention to data, when there's attention to intersectional data, also of the populations that you're working with, because otherwise that's the biggest challenge that we face, is that all of these fascinating and very interesting projects that provide critical knowledge to policy making, then suddenly are faced with, I think, 2 challenges. One around the funding, scaling up and just reproducing the science elsewhere is not something that is easily fundable in the system. For researchers, it's exactly the same for basic science. Replication is critical. Nevertheless, it's not funded. I think it's unfortunately the same in that kind of research, that you need, if you want to do it somewhere else, it's going to be difficult to get funded. Another challenge is that the environment is so different from place to place that, you don't control any variables of your environment and such a thing. So recognizing that there is huge potential impact, and especially for certain communities that Dr. Wood was mentioning, and I think that there are some great opportunities to work even further with the First Nation, Métis, and the Inuit communities, and to expand that research to see how that can be replicated elsewhere.
Let me pose another question about interdisciplinarity and to all the panelists, but let me start with you, Dominique. this is the first time we've had a vice president from SSHRC participate in a Health Research Foundation seminar, as far as I can recall. And it's important because this is inherently a social science activity and a humanities activity in some respects. So, but there's also, of course, a hard health sciences aspect to this. And Dr. Wood is a PhD, not an MD. I think I've got that right. And yet we have Dr. Avchil, who is an MD. And so we're looking for, I think, an understanding of how do we ensure that there's interdisciplinarity with rigor in the study of these subjects.
It's been a focus of the agencies, and my colleagues at CIHR and ourselves are working very closely together in finding new ways of approaching this. It's never easy because there are cultures in the different, but at the same time, social sciences and health sciences have been collaborating for so long that there are some epistemologies that are being shared. And when we talk about mental health, you can see it from both perspectives, from the social health perspective, some social sciences or the humanities perspective. So I think that we're improving on that part. Interdisciplinary students that are being put into interdisciplinary environment very often will report better outcomes for themselves, and so it does tell us that it is a better environment in terms of training and in terms of also outcomes of the research. Whereas the challenge is that you still need your specialist, and when you're a specialist, you learn a language. And your community is very strict. Your research community is going to be very strict about the language that you use if you want to get funded. And then you need to relearn later on the language of the other community to be able to collaborate. So definitely a great challenge, but that often results in the much more interesting outcomes.
It strikes me, and I'll turn to Martine, the public health is one of those areas where the social science and the hard medical sciences come together, and biological sciences, life sciences. And really, from the patient perspective, you already mentioned, Martine, the point about the immunological response, and in particular the patients that you represent, the challenges that they faced during COVID. Do you want to just talk a bit more about how the systems have to be structured to deal with that?
Yes, very good question. In the system is very structured. It's very much evidence-based. It's made decisions based on, the availability of the information. And we've seen, during COVID, where some decisions have been, sort of made rapidly based on the data that was available at the moment, and thinking about the second dose for the timing of the second dose in many patients. Remember Canada, the decision was made to delay the second dose of the COVID vaccine by 4 months, as opposed to what was recommended by the manufacturer. So when you're a patient and you hear this, you wonder, well, is this, and your immune system is already taxed. What does that mean for me? So, that the system doesn't always take into consideration the impact on the patient's well-being and, mental state, level of anxiety. I mean, patients are connected. The internet, gives them the opportunity to talk to other patients like them in other countries or in other regions of the country. And they wonder why, why me? Why do I have to, wait? My life is just as good as somebody else, and I should be as protected as somebody else is. And so, the system doesn't always think about it from an individual perspective. They think about it from a holistic perspective. Mm-hmm. And that, public health is designed to do this. But, is there a way to have a more considerate component of public health that will deal with the impact on, the individual patients? Because mental health is, you know, so critical, and the ability to control your disease, have access to the care that you need, being both the medication to treat, you know, your particular cancer or other disease, but also to deal with the impact on your well-being, your mental well-being. And that's something that, you know, the health system during COVID kind of, you know, went out the wayside. And I think we're realizing now the impact of, you know, the pandemic, distanciation, staying at home, wearing a mask, and all of that on the human being. We're seeing, you know, there's an amped up demand for, you know, social contact. So that's, you know, really important. And I also want to, you know, emphasize the fact that there are cultural differences as well, and, you know, sort of difference in you know, the way that people, Canadians, were a mosaic of different, you know, culture. And, you know, we think about the Indigenous population. I mean, you think about, you know, the South, the Indian population, South Indies population, etc. I mean, their approach, or the Chinese population, their approach to disease is all very different, and how they lived the experience through COVID. You know, we also have to think about that from a public health perspective, and incorporate, you know, the lessons learned into, you know, a variety of different, you know, people within our country, which, you know, many of the other countries may not have had to do, or may not have to do the same extent as we do.
That's a perfect segue to Suna, who, you know, Amgen has to deal with this curious population here, and the array of diseases. How does a medical director choose the research to undertake?
The COVID times was not easy times for research, for sure, and also prioritize for the patients where to focus. So from a research perspective, I think Health Canada did a great job of helping us by allowing, you know, remote monitoring, or, you know, other protocols or engagement with the centers were allowed, which helped, but was not ideal. And previously you asked about the benchmark. I think in Canada environment we did well on this. At least I can talk on behalf of my company that Amgen Canada was successful in most of the delivering on the clinical trials and everything. The challenge was that, and we are also currently looking at how pandemic disrupted the healthcare systems, and what does it mean for the patients. And if I touch, for example, the osteoporosis patients, we are working on a manuscript right now, a publication about this, that we see the patients are there, so they did not disappear. So even though the elderly patients stayed home, they still had fractures. They still need care, which I mean, we don't want, when we don't want them to go to the hospitals, they need this care. So definitely we need to work on the health resiliency, and to do that, real world evidence studies together with epidemiologists, together with institutions, to have data that will help health authorities to make decisions, to bring to the table for the discussions like Dr. Wood's projects will be really important.
And so, Dr. Wood, and tell us about how you see the integration of all of these different threads.
Absolutely. And I just want to emphasize, I think all of the points that have been made are ones that were going through my head as well. And, you know, there's a catchy little phrase, and I'm probably getting it wrong, but relevant research must be rigorous. So we need to be rigorous in our approach to knowledge generation to produce research that is meaningful. Because, you know, what else are we getting other than things that don't make sense or mean anything to either local communities, populations, health systems, that sort of thing. So I definitely second that. And I think that the multiple perspectives and research paradigms, I think that we do need to perhaps broaden our understanding of what rigor is. And Martine, you made such a beautiful point about the different knowledge systems that exist in Canada, and being willing and flexible to sort of work with that and negotiate that. But I think ultimately it does come down to, we need good evidence. But I think where the question is, and this is just how research works, is that we'll continually improve what our definition of good evidence is. And so we have to do the best that we can. And the reason is that that's what's most useful and meaningful for the people who will use that knowledge.
Thanks, Brianne. That's a perfect setup to my last question, which builds on your land acknowledgement, which I thought was one of the best I've heard, because it linked the recognition of Indigenous peoples and their land and their relationship to the land to the research that you're undertaking. And so it wasn't simply checking the box that you had done a land acknowledgement. And I'd like to explore that element of this, that place and disease and cure are related, and that we need to think about how traditional knowledge can be integrated with the traditional research of settler community, as some people would say, but I would say traditional, the usual kinds of research, rigorous scientific enlightenment-based research would lead us. And so we have the privilege of having the Vice President of SureCare. So tell us about the role of traditional knowledge and the role of RCTs in doing research. 25 words or less, Dominique.
I think they're just equivalent, it's and it was Martine mentioned it, it's just a different perspective, and we forgot, that there were other perspectives, and the Indigenous knowledge systems perspective was the last one that we suddenly acknowledge exists and suddenly gives credibility to, which is quite astonishing. And unfortunately, I wish I was wrong in that, but health research in the past, very medical health research in the past, sort of objectify negatively the Indigenous bodies. Everything that was reported was always sort of increasing the biases, or at least reinforcing the biases that we can have thinking about First Nation, Métis, and Inuit people. So it's a huge change to be able to move towards a system that is able to bring together the two. And I think Brianne, you mentioned, to provide you need to be rigorous science, and that's the first and foremost challenge, is that the two communities don't talk to each other, they don't have the same language, and the capacity to develop rigorous results with that will take time. And as a research funder, as a foundation is, we need to recognize in everything that we fund that they need time, they need resources, and it's going to take some time before we redevelop that epistemology in that language.
Martine, you raised it originally. Do you want to elaborate? And the fact is, Indigenous people get multiple myeloma, and they and several use traditional medicine, which may or may not be subject to randomized control trials, et cetera.
No, I thank you. Yes, that's totally true. And it made me think of, 10 years ago when we talked about real world evidence. I mean, that was kind of a, taboo, or like it wasn't just worth anything really. Clinicians, researchers were, very skeptical about the value of real world evidence. It wasn't real science. It wasn't real, sort of evidence collecting information to inform decisions. And, you know, what was valid at the time was, you know, double-blind clinical trials, randomized, you know, phase 1 to 3, and that was about it. That was, you know, considered really good research. But now we've evolved our thinking to look at real-world evidence as a tool to be able to make decisions or make evaluations about, you know, new treatments that are currently, you know, available. So, you know, if we're open to change our mind about the value of real world evidence, I think we look at what the Indigenous population and their ways of looking at care and holistic approach to the human being, as opposed to the disease itself, you know, will really enlighten us moving forward about how we treat, and we look at the person and treat the person rather than the disease.
Great line. And so as the token male on this panel, I have to ask Suna how gender plays into this as well.
Oh, actually, I was preparing to respond to you about the project. So let me talk about the project and come back to the gender maybe. Last summer, we had a project. 2 interns from the University of Toronto joined us to complete a research project about biologic treatment hesitancy among Black and Indigenous populations in Canada, because we were observing through our medical information service that there is, you know, different questions, approaches, acceptance by the patients based on their ethnic background. So these interns reviewed the literature and also looked at our own local processes within our Engine Canada medical information team. They identified gaps in delivery of medical information and how better we can meet those patients' needs. They provided some solutions, about, like, for example, generation of knowledge production. So the training materials could be different. It's also, they also found out that how cultural and socioeconomical issues, perceptions, impact, influence by their neighbors, the societies around them, are creating phobias, creating some misperceptions about the medicines, etc. So it was a really valuable and eye-opening, I must say, a research project. The article is submitted to the journal and it's in review now, and hopefully it will help. And accordingly, also, we are making some projects, working on projects about clinical trial patients, investigators, so how we can increase diversity on this. And it's an important topic for the company, not only for Canada, but globally. And similarly for females as well. So we constantly discuss that actually our patients, if they are not female, they have a female who are supporting them. There is really someone, a female caring the patients. So we need to really think from this angle as well, and trying to approach it holistically with our, educations or, the information we are providing to the patients.
Great. So for the last word, I turn to the Health Research Foundation Fellow in Health Systems Resilience, Dr. Brianne Wood. 25 words or less, sum up, please.
Sum up the whole conversation. I mean, I think that it's really important, that we have understood that there are many, underserved communities, and that disparities were enhanced and brought to light during the COVID-19 pandemic. And, I'm focusing on northern, rural, and remote populations, but there are similarities across different underserved populations. And so really what we need to do is do meaningful and rigorous research, bringing in multiple perspectives and aiming to create an impact while recognizing different knowledge systems. So I think that's the key learning that I've taken away from this conversation.
That's great. Look, thank you all very much. Brianne Wood, Srinivas, Martine, Elias, and Dominique Perry Bay. This has been an excellent conversation. We all really do look forward to seeing you, Dr. Wood, present again with your results next year. So power to you. Thank you all very much.
Thank you.
Thank you and congratulations.
Congratulations, yeah, for sure.
Thank you, everyone.
Thanks to all of you for providing such thought-provoking questions. Now it gives me great pleasure to introduce this year's winner of the Health Research Foundation Medal of Honor. Since 1945, the Medal of Honor is awarded to individuals whose research and contribution to public policies in Canada have garnered domestic and international attention. These recipients have made a pivotal contribution to the advancement of knowledge in health sciences and health research. They've originated from a variety of fields, including patient groups, educators, journalists, industry, and the public and nonprofit sectors. The prize is invested back into innovative health research at the Canadian academic facility of the recipient's choice to promote further life sciences research in Canada. Past winners of this distinction make up an impressive list, from Sir Alexander Fleming to the Right Honorable Brian Mulroney. Joining that list will be Dr. Astrid Guttmann, Senior Scientist at the Child Health Evaluative Sciences Program at the Sick Kids Research Institute, this year's recipient of the prestigious Health Research Foundation Medal of Honor. Dr. Guttmann is a world-class scientist in health systems performance and policy evaluation related to the care of children and youth. She has enjoyed an eclectic and important career devoted to the reduction of inequities in child health. Dr. Guttmann's leadership in Canada has had a significant impact on the broader community of health services and policy research, as well as building capacity and supporting those focused on maternal and child health. Since 2014, she has served as the Chief Science Officer at ICES, Canada's largest internationally renowned health services and policy research institute. In this role, Dr. Guttmann spearheaded the creation of data registries, health system performance measures, and infrastructure. This infrastructure is widely available through open access to researchers across Canada and worldwide. With these tools, Dr. Guttmann's lab and others are able to characterize cohorts of children, their healthcare use and costs at the population level and longitudinally, investigative gaps in care by socioeconomic status, perform real-world effectiveness studies of current and newly implemented models of care and other health system interventions, and produce rapid cycle reports for policymakers. This infrastructure revolutionized access to previously inaccessible data to inform decision-making at the health system level by making this data available to all researchers, and has been replicated in other jurisdictions, ultimately improving healthcare across Canada and more widely. She also has worked to make useful child health data accessible to communities, including First Nations, as well as community organizations. A respected mentor, Dr. Guttmann has trained countless protégés in the field of child health services and policy research. Part of her ongoing commitment to increase the number of research professionals focused on child health equity across a range of areas, including in mental health and addiction systems. In working with refugee communities, Dr. Guttmann, in collaboration with federal ministries and top policymakers, has been instrumental in helping government to more carefully consider the impact of healthcare reform and policy on children and youth from marginalized communities. Her current research has informed the impact of the COVID pandemic on children and families, and her work continues to provide reliable measurement of these important outcomes, bringing evidence to policy. Dr. Guttmann's work has had a profound effect on child-related healthcare policy, both at home and abroad. No doubt her vision, talent, and diligence will continue to shape and improve the lives of children and youth at risk, both at the national and international levels. On behalf of the Health Research Foundation, I congratulate Dr. Guttmann on this well-deserved distinction. I now invite Dr. Guttmann to say a few words.
I would like to thank Mel Kapp, Chair of the Board of the Health Research Foundation, for those kind introductory remarks. I'm very honored to be receiving this award from the Health Research Foundation and grateful to have been nominated by the Hospital for Sick Children. I am so lucky to have the support of two world-class research organizations that are my professional homes, the Sick Kids Research Institute and ICES, formerly known as the Institute for Clinical Evaluative Sciences, as well as the University of Toronto. I have a number of incredible mentors, and I work with a dedicated and smart colleagues and students who want research to make a difference in the lives of children and their families. I'm passionate about a number of things. The first is that as Canadians, we don't do so well by our children. In the latest UNICEF report, amongst rich countries, Canada ranks 30th out of 38 across a number of measures of child well-being. And within Canada, we have inexcusable inequities in terms of which children flourish. To paraphrase Sir Michael Marmot, inequities are not a footnote to the determinants of child health, they are the main issue. The pandemic and its associated societal impacts, the full extent of which we don't understand, have disproportionately impacted children and families from lower income and racialized neighborhoods, as well as First Nations, Métis, and Inuit communities, and our call to action to address widening inequities. But the second thing that I'm passionate about is that applied health research has a critical role to play in addressing these inequities. We are fortunate in Canada to have population-based data systems, not just from the healthcare system, but from social services and education that can be leveraged for research. I spent a large part of my career wrangling with these data. We have built institutes like ICES that work closely with government to inform and evaluate policies, bring the lens of these social determinants of health to analyses, and help efficiently interrogate and address inequities and build accountability into systems of care and services. Finally, we have as a field, arguably a little late to the party, started to appreciate the importance of evolving people, patients, the public, and communities to articulate the pressing issues, drive more of the research agenda, and co-design the way the work unfolds. There is still much to be done. I was very interested to see how much of the current funding of the Health Research Foundation is aligned with some of what I have reflected. I am so grateful to work in these interesting times and on compelling issues. And again, my heartfelt thanks for the honor of this award.
With that, another Health Research Foundation conference comes to an end. I trust you found it as engaging and insightful as I did. I'm sure you'll agree with me that this year's conference and awards were truly representative of the HRF mandate to advance and award excellence in health research in Canada. By promoting quality care for populations at risk, through outreach to northern, rural, and remote communities, through initiatives providing aid to vulnerable children and youth, and through continued influence on federal healthcare policy, our founding principle to enhance the well-being of all Canadians takes another step closer to reality. Medicine must not only be innovative, it must also be inclusive. Otherwise, for all of our effort and intention, we risk insularity, inequality, and injuriousness. Just as we continue to break barriers in research institutes, pharmaceutical facilities, and hospitals, we must continue to break them geographically, demographically, and socioeconomically. The COVID crisis, exposing as it has the holes in the healthcare fabric, has affirmed the truth and importance of this battle cry. Healthcare research networks need to expand, dialogue needs to deepen, outreach needs to extend further. Most of all, innovation must continue to be supported, developed, and readily offered to those whose rightful well-being is under threat, be they at hand or at a distance. If we innovate for all. Thank you for participating and have a great afternoon.